this is like an experience from my 15 years working with muscular dystrophy in Egypt. And I've been working also in developing the first neuromuscular center in Iraq. So I will go quickly about an introduction on Duchenne muscular dystrophy. It's DMD is a lethal X-linked recessive neuromuscular disorder caused by mutation in the dystrophin gene that result in absent or insufficient functional dystrophy. In Egypt, there is only one report on the prevalence of Duchenne muscular dystrophy done in Upper Egypt, and Upper Egypt is the south of Egypt, and the results says it's around 7.7 per 100,000 male births. Progressive muscular damage and degeneration results in muscle weakness, associated motor delays, cardiomyopathy, loss of ambulation, respiratory impairment, and skeletal deformities. Dystrophin, this is the dystrophin is a cytoskeletal protein critical for the stability of the muscles. And when we try to explain to the families or the parents or the patients, please try to think about dystrophin as if it's a pillar in a building, and without having the dystrophin, the connection between the extracellular matrix and the actin will not be there, and the muscle cell will progressively get damaged, or like a building falling down quickly. The dystrophin deficiency leads to rupture of the muscle fiber membrane during contraction, which causes impaired intracellular signaling. And because of the membrane is impaired, that's why a lot serum CK and transaminases level increases coming out of the muscle cells. So it's the DMD Patient International Care Protocol was updated in 2018, and we try to follow actually the standards of care since we started working with DMD patients. But because in our part of the world, we don't have access for gene therapies, except like we can say that less than a handful of patients have access to gene therapy, and also the standards of care or the patient's care is not well developed in every part of Egypt. So the standards of care, like we have to try to go around so that we can deliver the best care for the patients that we have. In 2019, MyoCare National Foundation was established as an Egyptian NGO governed by a board of directors from Egyptian experts in multidisciplinary patients. And we have also in the board an LGMD patient with us. The scientific director appointed at that time was my mentor, Dr. Ichizu Nishino. He is the director of Department of Neuromuscular Research in NCMP Tokyo. And also, MyoCare started to hold the Egyptian Neuromuscular Registry. The Egyptian Neuromuscular Registry, I started working on it after returning back from Newcastle in 2013. And actually, it holds more than 1,500 genetically confirmed DMD patients and more than 400 LGMD patients genetically confirmed as well. Since 2018, as a team, we visited medical centers in remote Egyptian villages. At that time, the awareness was just starting. I think by now, many patients and parents and even the community are more aware about the Duchenne muscular dystrophy and the importance of early diagnosis and applying standards of care. At the time when we started, we were struggling with convincing the parents, why should we have diagnosis if there is no therapy? Why should we have follow-ups if as they think that Duchenne muscular dystrophy will end up with no treatment? But actually, I'm happy to say that now the awareness is better, and patients are eager to get diagnosed in hope for reaching the therapy in the future, or at least because as they see some, in Egypt, there is a big population and the families are very big. So they may have a family member whom they lost before because they didn't start follow-up early or because of the cardiac respiratory problems. So they start to think again about following up with a neuromuscular specialist. In the DMD patients' first clinical visit at different stages, we see them at different stages. I want to share with you this, for example, this patient came to me when he was 4 years old, and the mother felt that his run is not very good, although he can run, but she was very smart, although she's coming from a village in south of Egypt. And he was very happy he wanted me to video him as he jumped up on the bed like that. Unfortunately, by age of 7, the mother stopped the steroids because of the idea about the side effects, although we talked a lot about how we follow up and we try to prevent any side effects, but because of the pressure of the society, she stopped all stretch exercises and steroids, and he returned back with contractures which didn't allow him to walk well, but we returned back to our normal program, and now he's getting better. He's 10 and he's still ambulant. This patient, he presented at the age of 6 years, and his main problem was the tiptoe walking. He had joint contractures, and unfortunately, this patient's first visit, this patient I've seen last year in Iraq. He's a 10 years old patient. His first visit was, he's already in ambulant having scoliosis, and he never had been to a DMD clinic before, or even a neurologist. Actually, there is we're facing a big problem. We faced it before in Egypt, and we're facing it now in areas in Iraq. The shame of showing our patients to the community because of their lack of ability to walk like other children, which we're trying to hard to change by giving awareness. So what's our approach if we have a patient suspected as a DMD? We do a full neuromuscular assessment. We have our own sheet adapted from NCMP in Tokyo, and but adapted. We changed some of it to fit to our Egyptian patients. We have to do CK serum level. We learned that we need to do echocardiography before even establishing the diagnosis if we suspect DMD or BMD, because genetic tests may take months until it returns back. And we lost one patient with heart failure. He was not diagnosed before, and no one thought that he may have a heart problem even. We do full lab workup, especially vitamin D and random blood sugar before starting any medication. We make sure that the patients had their standards vaccination, and then we ask for genetic testing. Genetic testing is sent to be analyzed either through labs that's sent abroad. We don't have labs that do the analysis in Egypt. It's very expensive, or they have to wait for their role in the national insurance, health insurance. Lately, it's available, but not always available, as it's always also it's sent abroad. In MyoCare, we collaborated with the NCMP, and they were very kind to provide us affordable testing for the last 10 years, yet an urgent need for tests to be done locally, and we're trying to find a way to do this. So when to suspect a case, when do we suspect a case? A positive family history, maternal uncle, brother or cousin, delay in walking, motor decline after normal development, difficulty running, jumping, Gower sign, using support to climb stairs. And actually tiptoe walking is one of the common complaints that patients come with. A high serum CK, even before the family can notice any motor delay. Some of them, after doing regular lab tests, for example, after a fever, unexplained fever or something, they find unexplained high serum CK or unexplained liver enzymes. And unfortunately, or fortunately now, most of the pediatricians, when they see that there is high liver enzymes without a certain cause, they refer to a neurologist or a pediatrician specialized in neurology. But before that, patients had undergone even a liver biopsy. Some of the non-motor symptoms sometimes are overlooked. We see a lot of learning attention difficulties and ADHD in the clinic, and autism spectrum. The age of first visit, in our experience, either at around the age of 3 with accidental discovery of elevated CK and liver enzymes, positive family history. If the mother is very smart and she can suspect, or she's worried, so she brings her son to be examined, and we do CK level for him, even by age of 2 or 3. Motor delay, motor regression, false step to walking, and late presentation. We see patients, unfortunately, with severe contractures or maybe loss of ambulation at the age of 7 or 8 because they've never been to a clinic before. Recently, in the last couple of years, there are few centers providing multidisciplinary care in one place, but they are also like 1 or 2 all through Egypt, mainly in the university hospitals. Sometimes the neuromuscular specialists play more roles, as not all services are available. We play the role of a psychologist and a nutritionist with our patients. The neuromuscular disorder specialist arrange with other specialists through referral letters. That's how I send my patients or refer them to a cardiologist or a pulmonologist. And we do phone calls and to discuss care plan, especially in case of patients who live in places far from neuromuscular disorder centers. Some patients actually travel a long distance and they go through many transportation services so that they can reach a center where there is a specialized neuromuscular specialist. Actually, for me, the first visit is very important. After establishing a diagnosis, I know how the family are shocked. Sometimes they're angry, frustrated. They have learned that there is therapy, novel therapies right now, but because we don't have access for this therapy, many families comes to me eager to join clinical trials in any country, and many of them try to send letters and emails and call and try to find a way to send their sons to any country that has clinical trials. Also, following the advice from social media, right now there is many WhatsApp groups for patients. They discuss together. Maybe some patients are not DMD at all, and the family give the advice because they're not really diagnosed, and they give wrong advice to each other. Experienced consultant in neuromuscular disorders has to be in the first visit to give support for the family and reassurance. An honest, simple approach in explaining the disease. We try to give it. We give them. We draw the diagram of the dystrophin gene, and we try to make them understand what are the consequences that may happen and how we can stop that with a multidisciplinary care plan designed to fit their where they are living, actually. Psychological support and assessing for cognitive function and trying to advise them to see a social worker. So on the follow-up visits, we recommend them to visit every 6 months. It's not usually they cannot do it every 6 months. Sometimes we ask them to send us follow-up echocardiography and tests on WhatsApp. We need regular medical monitoring for the contractures, for the muscle, and to make sure that they are still on the steroids and there's no side effects from the steroids. We try to teach them about morning headaches, about how to follow up with the blood pressure, how to follow a good nutritional plan to avoid the side effects of the steroids. Also, we try to teach them about to avoid bone fracture, because most of the patients that I've seen in the last 15 years that lost ambulation early is either because they had ankle contractures and they did not go through stretch exercises or use the splints well, or because of the fracture and immobilization for 2 months, and that's why they lost the ambulation early.
Dr. El Sherif, I'm really sorry to interrupt you, but you have still many, many slides and a few
Yeah,
minutes.
I will go through. Okay, sorry.
No, we were very interested also what you're doing in Iraq and so on. So maybe you can skip to that one, because this
Yeah. Okay.
what
So
Thomas
what's
had to do as well.
important? Yeah, we asked them to do exercise because the boys wants to do football, so we let them do swimming, which is good for their scoliosis. And we have on our Facebook page stretch exercises that the mother can do at home. Orthosis, we have problems with finding a good quality, and also if the calf hypertrophy is very big, it limit their use. But we advise for surgery but with early mobilization and physiotherapy. Also, we started using the non-invasive ventilators, but because it's not covered with the National Health Insurance, it's very hard for some patients to get it. I will. So this is the first Egyptian patients to have exon skipping therapy. We've been following up with him since he was 3. He was very compliant, and that's why he had good muscle power and no contractures when he started on the exon skipping therapy. And but unfortunately, the parents had to pay for the whole price. There is a burden of traveling, and that's why actually, and also we did a study about the socioeconomic burden on the parents and the families, and we found that because they pay everything from their pocket, they stop following up and they stop doing the physiotherapy. We tried to start telehealth systems through giving Zoom meetings and asking the parents to send the investigations through WhatsApp. But the problem is that not everybody has a good connection or a smartphone. So we had limited number of neuromuscular specialists. There's no dedicated centers for DMD and limited local genetic test labs. Families prioritize ambulation and may neglect other needs, and social stigma and maternal blame. Most of the families, the mother get a divorce and she's the sole person taking care of her children. This is the awareness that we try to do, through the years with many families and even in the television. This is the hospital where the MyoCare now is collaborating with the New Giza University to provide free Duchenne muscular dystrophy and clinics. And also education. We had 2 consecutive, in 2022 and 2024, DMD outcome measures educational course. And we started research in Iraq. Actually, we were invited, I was invited among others with my mentor, Dr. Nishino, to start the first neuromuscular center in Iraq. There are some pediatricians and neurologists in Iraq who understand about Duchenne muscular dystrophy, but there is no specialized center that can be a referral center for Duchenne muscular dystrophy or muscular dystrophy in general. So So we started planning for clinical setting. We started from scratch. There was nothing. We started the clinical sheet. We started having a screening system for patients, because we used to have patients with any type of weakness because of any maybe upper motor neuron lesion or something. We developed a database, a computer database for the patients. We put a strategy for the diagnostic approach according to the clinical presentation. We did training for the MRI technicians for doing muscle MRI protocol, and this is actually, it's done for all patients, at least once per year, determining criteria for patients who needs only genetic tests like DMD and when to ask for muscle biopsy. Special lab, we started a special lab inside the center to provide the CK serum level, among other regular tests, and DNA extraction to send genetics test. Unfortunately, it's not yet done in Iraq. And also there is a rehabilitation center. We have 2 pediatricians, 2 neurologists, and 2 neurophysiologists, and a team of physiotherapists. We train them on how to do stretch exercises and the importance of avoiding scoliosis and contractures in patients with Duchenne muscular dystrophy. The center is in a place called Karbala. Karbala is 2 hours away from Baghdad, but actually patients come from everywhere from Iraq, because they were like, this was, at least they found someone to care or to give them information about their patients and management plan. This is actually last month we had the approval to start the first national patient registry in Iraq, and we will start working on it starting from next month. This is my team in Iraq in the clinic, and this is the physiotherapist. This is my colleague who's doing the neurophysiology, and last week we had the second neuromuscular center conference with, we invited neurologists from all over Iraq to give them some kind of advice and to give them awareness about what the center does, so that they can refer to us their patients and give them the management plan. I know I've almost finished, that's all. After all this, my only problem is that we need urgent start natural history studies in our region. So I hope that we can do this one day. And thank you very much. These are my colleagues and collaborators. And thank you for your time.